Left ventricular measurements can be obtained by M-mode or two-dimensional methods. In most cases of mild or moderate mitral insufficiency or regurgitation, left ventricular measurements and function are normal. The main goal of obtaining left ventricular measurements in mitral insufficiency is to note whether abnormal left ventricular diastolic size, fractional shortening, and ejection fraction support severe or advanced severe mitral insufficiency. In most dogs with mitral insufficiency, left ventricular size in diastole is within the normal range. In advanced stages of severe mitral insufficiency, the left ventricle becomes larger than normal, indicating volume overload. When left ventricular volume overload is present, prognosis becomes poor and treatment with digoxin may be necessary. Fractional shortening is a percentage change in left ventricular size between systole and diastole. The normal range of fractional shortening in dogs is not universally accepted. For the purpose of this DVD, a range of 28 to 48% will be used. In most dogs with mild to moderate mitral insufficiency, fractional shortening remains within the normal range. In severe mitral insufficiency, fractional shortening exceeds the normal maximum and indicates good condition of the myocardium. Decreased resistance caused by two exits from the left ventricle, the normal aortic exit, and a large abnormal mitral leak, causes overcontraction of the left ventricle. In mitral regurgitation, more than half of the total stroke volume that should be going forward through the aortic valve may be ejected retrograde into the left atrium. Excessive fractional shortening in mitral insufficiency indicates that the myocardium is still capable of overcontracting, and prognosis is better. In the more advanced stages of severe mitral insufficiency, fractional shortening drops back into the normal range, indicating myocardial failure and a poor prognosis. The myocardium is no longer capable of overcontracting due to death of myocardial cells and replacement with fibrous connective tissue. Should the patient survive this severe stage of mitral insufficiency, fractional shortening will eventually drop below the minimum normal range, indicating progression to acquired dilated cardiomyopathy. So much cardiac muscle has been lost that the left ventricle can no longer achieve the normal range of contraction, and prognosis is poor. Ejection fraction is the percentage of left ventricular volume ejected with each heartbeat and correlates closely with fractional shortening. The normal range for ejection fraction in dogs is 55 to 80%. Ejection fraction exceeding 80% indicates overcontraction and a better prognosis in mitral insufficiency. Values below 55% suggest decreased contractility and a poorer prognosis. In a two-dimensional, right-side short-axis view of the normal mitral valve, the valve shows thin but irregular valve leaflets. In a two-dimensional view of a diseased mitral valve, thickened lesions can sometimes be seen on one or both mitral leaflets. Endocardiosis of the mitral and tricuspid valves is characterized by an accumulation of glycosaminoglycans, a myxomatous proliferation, and fibrosis of the valve leaflets and chordae tendineae, leading to valvular regurgitation and eventually congestive heart failure. Degeneration begins with subendothelial deposits of mucopolysaccharide and areas of fibrosis producing a ballooning or thickening of the valve leaflet or chordae tendineae. A lack of visible valvular lesions on ultrasound does not rule out the presence of endocardiosis. Valvular lesions of endocardiosis can also be seen on the right side long axis four-chamber view and the left apical four-chamber view. In this normal M-mode view of the mitral valve, the leaflets appear as thin hyperechoic lines. The M-mode of a diseased mitral valve shows thickened leaflets or focally thickened lesions. Normal E-point to septal separation distance is less than 0.6 centimeters or 6 millimeters. An excessive E-point to septal separation measurement would support an increased left ventricular chamber size in diastole, or a left ventricular volume overload. Prolapse of the mitral valve leaflets is caused by stretching or partial rupture of chordae tendineae. This results in a ballooning of the mitral leaflets into the left atrium during left ventricular systole. Mild prolapse is best seen in the right side long axis four-chamber view. Prolapse can be described as mild, moderate, or severe, and generally corresponds to left atrial size. Flail leaflet is a severe form of prolapse due to severe or extensive rupture of some chordae tendineae. Part of a mitral leaflet can be seen moving completely inside of the left atrium during left ventricular systole. Flail leaflet can be acute or exist for a matter of several days or weeks. It indicates severe mitral insufficiency regardless of left atrial size. In cases of acute rupture or chordae tendineae, the left atrium has not had time to dilate, and sudden death can occur. Patient survival may be very short, and prognosis is poor with flail mitral leaflet.